Apologies all, we're just having some technical difficulties with our chair, Hywel Jones, coming live. Please bear with us for 1 minute. Thank you.
Okay, good morning everyone. Bore da I chi gyd. Apologies for running a few minutes late. My Teams crashed at just the perfect time this morning. So yeah, bore da, chroeso cynnes I chi gyd I bedwerydd diwrnod wythnos gwerth mewn iechyd. Good morning everyone and a warm welcome to you all to the 4th day of Value in Health Week. We've had a fantastic week so far and more great sessions to come, and I just wanted to take this opportunity to thank those who have worked so hard to make this week happen. Diolch yn fawr iawn. I'm Hywel Jones, Director of the Finance Delivery Unit here in NHS Wales, and I'm delighted to be joined this morning by Dr. Alice Andrews, Director of Education for the Value Institute for Health and Care, Dell Medical School at the University of Texas, Dr. Zoe Wainer, Deputy Secretary for Public Health at the Victorian Government Department of Health in Australia, and Joseph Casey, Director for Partnerships and Programmes at King's Health Partners in London. Bore da I chi a chroeso I Gymru. Good morning and welcome to Wales. Thanks for joining me this morning. We're very grateful for your time and looking forward to hearing from you. So the purpose of this session, value-based healthcare across the world, is to explore and describe value-based healthcare and its application across different healthcare systems. We want to explore and discuss commonalities and differences in our approaches and the opportunities for learning from each other at this critical stage where value-based healthcare must be central to our recovery from the pandemic internationally. From a personal perspective, I'm really passionate about the potential for the value-based healthcare community to collaborate and share practice. My own knowledge and experience was developed immensely when I was fortunate to spend a week with Alice and the fantastic team at Dell Medical School a few years ago. So from first-hand experience, we have many great things to learn from each other. In terms of format for this session, I'll be kicking us off briefly with a Welsh perspective, some of which you will recognise and be able to contextualise this week's sessions, and then we will hear from Alice, Joseph and Zoe in turn on their system perspectives before drawing that together with some themes and question and answer at the latter part of the session. Please use the chat bar to ask your questions as we go through the session, and we will endeavour to respond to as many as we can. Next slide, please. So from an NHS Wales perspective, we consider this definition to be the closest to what we are trying to achieve. Value-based healthcare is the equitable, sustainable and transparent use of available resources to achieve better outcomes and experience for every person. As a population health, planning and delivery focused system, maximising the outcomes we achieve for every person in the population is our goal. Next slide, please. And how, therefore, do we achieve better outcomes for patients in achieving sustainability? And a number of these have been touched upon in various sessions this week, but from a patient perspective, it is critical that we raise and enhance health literacy and support healthy behaviours that are focused towards prevention and optimising quality of life. It is crucial that we support shared understanding of medicine and interventions towards the best choices and ultimately support every person through supported self-management where patients are empowered with the right information and choices to support their own decisions. Equally, we know that from a healthcare perspective, to sustainably optimise outcomes for patients, we need to optimally allocate and prioritise how we use resources, incentivise high-value interventions and best practice, decrease unwarranted variation and low-value care, and tailor treatments to individual goals and context, which will include addressing their place of care and new models of care such as digital health. And through that, we need to focus on meeting true need and addressing and reducing inequity. Next slide, please. So in delivering value in healthcare, we know that optimising outcomes that matter to patients can only be achieved through considering all interventions along the pathway for the whole pathway of care, so that we make optimal and informed decisions on how we utilise resources to achieve best outcomes. Whilst there are many ways to improve outcomes and sustainability across the healthcare system, you will have heard through the sessions this week on our focus on reducing unwarranted variation in care pathway delivery, to release capacity and the investment in secondary prevention approaches to improve outcomes and minimise harm. This was perfectly demonstrated for those of you who joined the session yesterday on lymphedema services in NHS Wales. Next slide, please. And Dr. Sally Lewis outlined earlier this week our area of focus on 6 areas which we consider will facilitate the delivery of value-based healthcare across the whole pathway of care for the population of Wales equitably. These 6 areas are clear, and as Sally described, will be the cornerstone of our refresh strategy when it's launched on Friday. I won't talk through all of the content of this slide because we want to get on to the sessions being delivered by our colleagues this morning, but they should contextualise a number of the sessions that you have seen this week, from Professor Hamish Ling's session on the Intensive Learning Academy and our approach to education, Adele Carhill and colleagues on our strategic partnerships, our approach to data and digital health from Dr. Alan Wardo and Navjot Kalra, and implementing this approach with impact, such as in lymphedema services and other clinical condition areas you have or will hear about this week. Next slide, please. To support that strategic approach, for the last 2 slides, I just want to offer some thoughts on the practical application of a value-based healthcare approach for NHS Wales, given we are trying to implement this approach across the whole system. You heard earlier this week from the Minister for Health, from Sally Lewis, from Ivan Evans, from Welsh Government, on our ambition for value-based healthcare, and it is exciting that our policy position, strategy and planning mechanisms are aligned to drive this forward. Across the system, there are multiple models and approaches to driving value-based healthcare, and we are attempting to balance national direction, strategy, prescription, where there are known high-value interventions, for example, with local planning and delivery of services that are tailored to meet the needs of the local population. The population across Wales is diverse and has multiple different dimensions to address in improving outcomes for individual patients. Prospectively, this will increasingly be reflected in how we allocate our resources to drive improved outcomes. We are considering how government allocates resources to health boards, how health boards distribute resources across pathways, and how organisations commission and contract with each other to improve outcomes. Our platform through the World Economic Forum and collaborations with international colleagues will be of great benefit in implementing this approach. All of this will be informed by a lot of the great examples you will hear this week, such as in diabetes, on how we currently utilise our resources and opportunities to improve value. Next slide, please. And finally, from me, you'll see over the course of this week some wonderful examples of practical application of value-based healthcare in a number of clinical areas, and there are some key Welsh attributes for me which stand out in those. Firstly is the critical importance of data to generate knowledge and inform actions to improve value and outcomes. Secondly, there is a multifaceted approach to value, and there are a number of ways and methodologies to drive improved outcomes, and we have real examples of that this week. It isn't a standard one-size-fits-all approach for every clinical condition. And finally, it is genuinely a team effort and a team sport. Implementing a value-based approach requires real teamwork, and you will see this week the strength of the partnerships across multidisciplinary teams, be they clinical, financial, managerial, or experts in multiple professional disciplines such as information, procurement, and so on. So that's enough from me, thank you. Diolch. I'll now hand over to Alice to talk to us about the approach of Dell Medical. Diolch, Alice.
Thank you, Hywel. And thank you for this opportunity to be on the panel today to discuss value-based healthcare around the world. As Hywel mentioned, I'm Director of Education and faculty with the Value Institute for Health and Care at the University of Texas at Austin in the USA. When we were planning this session, Joseph, Zoe, and I, all of us said to Hywel, wait, the work in Wales is at the global frontier. How can we best contribute to this discussion? And over this week, you've heard about the work, as Hywel mentioned, many examples of it, and the support for value-based healthcare across the country. So here I am from Austin, Texas, and I'm just, by the way, I suppose a proper Texas greeting would be happy to be here today with all y'all. So the US typically thinks we're best at everything. You probably already know what the US is best at in healthcare: highest cost. We're at the very top. We have a lot of expensive procedures and yes, some advanced technology and scientific know-how, but these things have not always translated into better health. And the US continues to drop in its place on most comparisons of population health. And these past 2 years have shown that we're not so hot at public health either. On the plus side, we initially ramped up getting vaccines to people, but now the US has fallen far down in the list of countries with high vaccination rates. These challenges and the recognition we need to learn not just from, but together with others around the world about how to transform health and care is what drives the work of my institute. One of our founders is Elizabeth Teisberg, author with Michael Porter of Redefining Healthcare. And our purpose is to create a platform for people interested in transforming health and care, a place where they can learn, they can share their experiences and teach and network with others. And this point of collaboration is very important. There's no place on earth delivering great health outcomes to all of its people. Instead, we share many similar issues: healthcare that isn't organized around the needs of the people being served, healthcare that doesn't improve quickly because it doesn't measure meaningful health outcomes. No matter the funding model, the area of care, the government structure, these problems are maybe surprisingly very similar around the globe. So our goal in transformation is to help people find what we call the steps within their stride, the actions they can take that can begin to deliver more effective, more efficient, and more compassionate care. Next slide, please. For the most part in our countries, we pay for what is done, not what is achieved. Outputs, not outcomes, the things you've talked about in detail this week. To reiterate, high-value healthcare is about better health for more people, the outcomes that matter to individuals and families, and measured for everyone. That last piece is very important because that is a way to improve health equity, something Sally Lewis mentioned on Monday, and I'm sure has been repeated during the week. Next slide, please. As you've listened to your colleagues talking this week about their great work measuring health outcomes, you can see that this important work can feel really hard to do. It requires a lot of time, steps, surveys, etc. And yes, getting down to the detail for a specific clinical condition requires all of these things. However, not all measurement has to be at that level. In the decade plus that our team members have spent talking to patients and to families, we've consistently heard that outcomes fit into 3 broad categories. The first is capability. What makes me, me? Capability is what patients have, it's what they're doing, what matters most to them. Better functional outcomes, whether that's about using one's feet for someone with diabetes, shoulder mobility for someone who's had an orthopedic procedure, cognitive capacity for someone who's undergone chemotherapy as part of a treatment. All capability. And we've done work with young adults, which is defined as age 25 to 39, who are going through cancer treatment. Beyond survival, they feel a strong loss of identity in how they look, in the things they can do, for example, fatigue from treatment. And more devastatingly, many of these patients were never asked or told about the impact of cancer treatment on fertility. So now this education is included every time and for all. The second area of outcome measurement is comfort. helping to manage the physical suffering, the emotional angst, the anxiety that goes along with treatment. For the young adults with cancer I mentioned, there was a lot of anxiety and fear about what would happen during treatment, about recurrence. And interestingly, many found it difficult to turn to family or friends. Yes, they were supportive, but they often treated these young adults differently. They didn't understand the experience. And in fact, some of these patients felt they might be judged because they got cancer at such a young age, like it was their fault. So a change was made to provide access to a counselor at the time of diagnosis, not just waiting until a mental health need arose. And so finally, along with capability and comfort, we talk about the need to measure what we call calm. Can your life go on during the treatment of disease? Avoiding the chaos that goes along with medical treatment. Can you manage your family? Can you manage your life? Can you get to your appointments? For these young adults with cancer, well, cancer treatment's anything but calm. Decisions, uncertainty, patients described it as a whirlwind of information. In the US, this is coupled with extreme financial toxicity. Many of these adults lacked insurance, or even with insurance, were going to incur burdensome costs they were not prepared to take on, especially at such an early age. And then, when treatment ended, many of these young adults felt they were thrown to the void. They no longer had that immediate support system and felt abandoned. The clinic added an advocate to help navigate difficult decisions and to assist with outside resources. I've given you examples specifically for these young adults with cancer, but this broad lens of capability, comfort, and calm has been used in other clinical areas and almost always surfaces issues of which the medical team was unaware or didn't realize wasn't being addressed elsewhere. It allowed the team to identify important services for whole patient care, and it has allowed different clinical areas to compare with each other. When you start with capability, comfort, and calm, you are starting with patients and where they are. This type of measurement is inherently deeply patient-centric. It's inherently and deeply relationship-centered. And it's a way to communicate earnest empathy. Next slide, please. At the clinics at Dell Medical School, as they began measuring capability, comfort, and calm for patients, the clinical team said they wanted to measure it for themselves. They felt it could be a way to reduce burnout and moral injury. As you all know, the past 2 years have been devastating for healthcare workers. Their resilience has been stretched beyond belief. They suffered deeply from the moral injury that arises from being caught between their deep dedication to improving health and our systems that often are misaligned with that goal. In a paper from 2018, Talbot and Dean stated that routine, incessant betrayals of patient care and trust are examples of death by 1,000 cuts. That has been the lived experience of most health professionals. It was bad before the pandemic. Again, this paper was 2018, but it's so greatly exacerbated now. So we need to be looking out for the capability, comfort, and calm of our healthcare workers as well. And this work has just started at Dell Medical School, but they're looking forward to finding answers to helping clinicians as they've helped patients. The goal of high-value healthcare, providing relationship-centered care that puts the health outcomes that matter to patients front and center, that focuses on what is achieved with patients rather than what is done to them, supports professionalism. It reconnects healthcare workers with the purpose of their profession, health. It supports resilience and a culture built on relationships and communication so that everyone, healthcare providers, administrators, patients, are working towards the same goals. Values about focusing on the purpose of helping those we serve and supporting the professionalism of those who serve. It doesn't mean that shift in thinking is easy. The work in Wales, it takes time. It requires a lot of thought and effort, and more importantly, back to the beginning, a global community of people to support each other in this work. Next slide, please. So thank you again for including me in your Value in Health Week. My contact info is on this slide. Please reach out. I hope to continue the conversation with many of you throughout the year. I'll also mention that in April 2022 in Barcelona, we'll be convening our first Redefining Healthcare Summit And the tagline is achieving transformation together, because that's what it will require. So thank you. And I'll now turn it over to Joseph Casey.
Thank you very much, Alice. It is absolutely a privilege to be here this morning. My name's Joseph Casey. I'm Director of Partnerships and Programmes at King's Health Partners. And we've had the privilege for many years to be inspired by work being undertaken in Wales, making progress on value-based healthcare. It does make this quite a daunting session, because normally when I'm asked to talk about examples of value-based healthcare around the world, I try to avoid talking about England and instead use Wales as my case study example. But unfortunately, there's many experts on this call who know much more about that than me. I will be told off by Professor Moxham if I don't say how brilliant everyone in Wales is in the progress. He retired 2 years ago, but is still following all of your work with fascination. So I know he's listening, so I had to say that. I want to share 3 reflections, which I will do when I go through my slides in a moment. So the first is, I think we're taking much of the same inspiration, whether in Wales, whether in England, across Europe, and indeed around the world, including the US-based models of value-based healthcare. And there's much value in that, but there requires continuous adaptation if we're going to be successful in our adoption of those models. I will talk about England specifically, as that's my brief today. There has been progress. There are fantastic examples of clinically driven innovation, informed and inspired by value-based healthcare models. But that progress, I think, has been much more fragmented than the progress that has been made in Wales. And I'll share some reflections as to why I think that is. And then finally, we'll briefly touch on similar experience across Europe and try to emphasize in those examples where I think there are opportunities for us through international collaboration, both to learn from what works, to develop that together, but also critically to learn where we're less successful, where we're not successful, and use that to inform our work together. So if I could have my first slide, please. So first of all, I actually just kind of wanted to pause and say, what do we mean by value in England? So much of the work has, of course, been informed by Porter and Teisberg's book, Redefining Healthcare from 2006, but very much as well by Muir Gray's work, particularly around evidence-based healthcare. And as I've said, there has been progress within the NHS, including in England. And I think this paper from the King's Fund from 2015 remains a very valuable contribution to understanding value-based healthcare. And if you click again, I think fantastic. 2019 definition that was shared right at the beginning of this session is the exact same definition that we use at King's Health Partners. And I think that's critical, because if you look at value-based healthcare examples in England, you could take value-based healthcare as a framework. Much of it fits into Porter and Teisberg's value agenda, but you could take many other approaches and say, actually, this is about evidence-based healthcare, this is about care redesign, and not use value-based healthcare as your kind of inspiration and strategy. And I'll share some reflections on the impact of that. And if you just click again, I think it brings up the reference. And I wanted to highlight, of course, that Sally Lewis was involved in developing this definition, but also colleagues from King's Health Partners, including Kate Hare, who leads much of our work across the South East London Cancer Alliance. Next slide, please. And why do I want to emphasize this? Because I think often people say the words value-based healthcare without knowing what we mean. And what do we, and I think that's really important to actually achieving what we're trying to together, as Alice was setting out. And I often turn back to this research from the Karolinska Institute that highlights that 25% of academic papers fails to understand the actual basic concepts around value-based healthcare. And I think that has implications for implementation. Next slide, please. So at King's Health Partners, we've tried to take inspiration from others, including in Wales. We've tried over the last decade to develop value-based healthcare approaches. I think one of the most important contributions we've made is in where we've not been successful. So there was some technically brilliant work undertaken at King's College Hospital, had absolutely nothing to do with me, which is why I can just share my opinion. Technically brilliant work undertaken at King's College Hospital right back in 2012, 2013, multi-professional team, clinically driven innovation. The most valuable contribution to the value-based healthcare field from that work was the evaluation that set out why did that work fail to actually have the impact that was intended. And that was about the system structures and the continuous supportive leadership to enable that clinically driven innovation. And so what we've done over the last 5 or 6 years is try to take a pragmatic, practical approach, building up our work through different pilots. The example on the slide here is from some of our work in orthopedics, but also in depression in older adults, and develop our understanding and capability through a series of kind of pilots that bring together that framework. And I think, if you click to the next slide, please, I think that experience is similar to many across England, and we've had some successes through that. So the AI Centre for Value-Based Healthcare, which is hosted at King's Health Partners, brings together many different organisations across the NHS. It is an example thinking about the value framework of spreading excellence across geography. It's developing the underpinning informatics platforms that enable the realisation of that vision of value-based healthcare. Next slide, please. Including in stroke care, so the AI deployment engine that has been developed at that centre has just gone live in King's College Hospital, supporting clinical workflows to enable personalised care, enabling clinicians to improve outcomes that matter with an infrastructure that actually significantly reduces the cost of medtech innovation within healthcare. So fantastic examples, but in England we continue to talk about examples rather than system levels, scale and spread of value-based healthcare. And if you click to the next slide, please. And I think that's because in England we've continued to not actually know what we mean by value, and that experience is similar across Europe. And value-based healthcare ultimately is a strategy that provides you with a framework for thinking about, in complex health and healthcare systems, how can we improve the outcomes that matter. There's significant work across Europe that's trying to take that same approach. And if you this 2019 report from the European Commission is a good survey of that. Some of that European collaboration includes colleagues across the European University Hospital Alliance, and we're trying to learn and share that experience, including in a paper that will shortly come out in Value in Health, as major infrastructure developments, including the Health Outcomes Observatory and different initiatives around healthcare transformation, including this Healthcare Transformation Academy focused on value in health. But where, for these examples to be successful in the way that you are continuing to make progress in Wales, I think a major missing and critical enabler is policy. And that's policy in terms of setting the vision, policy in terms of providing strategy, but policy in terms of understanding the role of leadership is to step out of the way, enable, support, make investments, but ensure, just linking back to some earlier slides, ensure actually that close relationship between locally driven implementation. So have I come here to say there's no role to play for England or indeed European colleagues in progressing value-based healthcare? No, I haven't. Actually, what I've come here to say is that it's through such collaborations that we've been able to learn, share our own experiences, take inspiration. And I think this session and the conversation we will have during the Q&A has been so important and valuable to us making progress. And my great hope in England is that integrated care systems will provide some of the framework that will enable us to make progress through a value-based healthcare approach. But whilst I could have come here and given you 10, 15, 20 examples from England of really impressive progress, I think actually for the effort and leadership that's gone in, we remain underpowered in actually the mission of improving the outcomes that matter for every person. So thank you very much for your time. And I will pass over to Zoe.
Thank you for that. Hello everyone, I'm speaking to you from the beautiful city of Melbourne and it's 8:30 at night, here. In Australia, we open our talks with an acknowledgement of country to show our respect for our First Nations people. So as we gather from various locations across the world, let's take a moment to reflect on the meaning of place, and in doing so recognise the traditional custodians of the land on which we stand. I acknowledge the Aboriginal and Torres Strait elders, past, present and emerging, and offer them my enduring gratitude and respect in the spirit of reconciliation. You can see also from my background, community, immunity and unity. This is from our First Nations people to drive uptake of COVID-19 vaccination. Well, I think we already have one theme today, and that is, I have to be honest, speaking to you all about value-based healthcare does feel a little like a first-year med student talking to a room of specialists, as articulated by my previous two colleagues. In Australia, we very much look to Wales for guidance, for expertise and collegiality. We're also incredibly grateful to be a part of this collaborative international community, as it's playing a vital role in improving Australia's health system. Next slide, thank you. So let me give you a little bit of a Cook's tour of the Australian healthcare system. As you can see here, it's pretty complicated. We have the public system, which encompasses public hospitals, community-based services and affiliated health organisations. These services are funded and governed by local, state and federal governments and accessed at low or no cost through a scheme called Medicare. Then we have the private system, which encompasses private hospitals, specialist medical and allied health, as well as pharmacies. The private system is funded by a combination of government and private entities. To access private healthcare, Australians need to have private health insurance, which they pay for themselves or they self-fund the care. There are means-tested government rebates available, but private care can still be very expensive for the individual due to gaps between what the provider or the clinician charges and what the insurer actually pays out, as well as other out-of-pocket costs. The benefit, of course, is you can access non-emergency care without going on the public wait lists, which are increasingly large as a consequence of COVID. Certainly not an ideal starting point for value-based healthcare, but as we know, there is never an ideal starting point. You just need to start. Next slide, please. To further complicate matters, healthcare responsibilities are split between the federal government, the state, territory and local governments. Here you can see a quick overview of who's responsible for what. The Commonwealth handles primary care, so GPs or family doctors, while the state handles the acute healthcare system. So you can begin to see some of our challenges to achieving integrated care. I've been in the privileged and unusual position of working in both private and public sectors during the pandemic. When the pandemic first hit, I was the medical director and head of public health at Bupa Australia and New Zealand. Many of you probably know Bupa, but for those of you who may not, it's a multinational company responsible for private health insurance as well as healthcare services. In Australia, that includes optical, dental, aged care, and in New Zealand, retirement villages. I was also the board chair of Dental Health Services Victoria, an agency funded by the state government to provide public oral health services across the state of Victoria. I'm now the Deputy Secretary of Public Health at the Victorian Department of Health, which is obviously part of the state government. These diverse roles have given me a lot of insight into the opportunities and challenges that exist when it comes to integrating the principles of value-based healthcare in Australia. Next slide, please. So let's rewind to May 2020, when I was working in the private sector at Bupa. I was actually the director of clinical governance, and we could see the second wave coming. It was like watching a high-speed train about to crash in slow motion. We knew what had transpired. We'd been able to learn from our UK and Spanish businesses, where Bupa has aged care in both countries. We knew that our aged care residents were going to die and our staff were going to get very sick. We knew we couldn't stop the train, but we wanted to at least slow it down and limit the impact. We looked at the international evidence and we saw that the best option was to get our residents out of aged care homes, particularly the older homes, and into a hospital setting where we could limit transmission of the virus and also ensure that they got the care they needed. But we couldn't find a way to partner with the local authorities and for them to feel like we were a genuine partner because we were seen as the private sector. Next slide, please. It's kind of sad to say, but the impact was predictable and devastating. We had multiple homes with significant outbreaks, and in those homes, some of our residents died more than had to, and we understood the virus. Had we understood the virus and shared a collective view with all stakeholders, Our staff started testing positive and several senior staff members ended up in ICU. At one stage, we had one nurse and 3 carers providing care to 87 sick residents overnight with the pandemic, making the care far more complex. We were on the phones telling families, don't worry, we will take care of your loved ones, because of course nobody could visit them. And our staff were extraordinary. They really did their absolute best in the most challenging of circumstances. Next slide, please. These were just some of the headlines in Australia at the time. The situation really shone a spotlight on the significant problems with our health system. COVID, as it has around the world, highlighted the fragmentation points of the system and the inequities of access to care. It showed just how vital it is to integrate the principles of value-based healthcare. Next slide, please. So what went wrong? Everybody was stuck in a siege mentality. There was no space for collaboration or strategy. We were in a frenzy of operations on the dance floor with no one on the balcony looking down at the bigger picture, which some might say is probably a good thing because the view wouldn't have been very scenic. Information was being drip fed and was often contradictory. We were all building the plane whilst flying it. The silo mentality meant that the private and the public sector were not working together nearly as effectively as they could. On top of that, primary health was seen as a Commonwealth responsibility and acute health was a state. Instead of drawing off the rich intelligence of this global value-based healthcare community, opinion was winning over evidence, and as we all know in a pandemic, pace over perfection is critical. The situation really highlighted how the system, as it stands, doesn't create an environment of trust. Stakeholders are set up to have diametrically opposed incentives, which makes it hard to trust in the current structures, let alone under the immense pressure of responding to a pandemic. If we want the private and the public sector to work collaboratively, including the federal and the state, particularly during times of peace and pandemic, we have to build that critical trust across the sector, which is fundamental to value-based healthcare. Is it any wonder that the train hit at such high speed? Next slide, please. Don't worry, the presentation isn't all doom and gloom, and I know that Australia certainly has had not nearly as much impact as other nations have. We've been very fortunate from that perspective, but we are learning and we have started doing things differently. So I'm now working for the Department of Health, and I can see a significant change, not just our approach, but the collective mindset of everyone from the coalface to the corporate office. The pandemic has highlighted 2 critical fractures in our healthcare system, as I said, integration and support for at-risk communities. We've seen how a lack of integration leads to really poor outcomes for the most vulnerable in our community. We are now entrenched in another wave of COVID in Victoria at the moment, of course, being driven by the Delta variant. And we've developed COVID positive pathways, which are a pathway that takes a whole of individual journey from triage through to discharge. Many of us here would actually refer to that as an integrated practice unit in terms of value-based healthcare. Our COVID-19 positive care pathways are underpinned by the principles of value-based healthcare. People are triaged upfront and primary care is deeply embedded in the system. After being assessed based on their severity, patients are matched with the correct provider, treatment and setting. We're capturing data and using technology to support the pathway. As we design the pathways from diagnosis to discharge, we're planning how they can be used to manage other conditions in the future. Next slide, please. Here you can see the pathway involves an interdisciplinary team coming together to design and deliver a comprehensive solution. This system asks healthcare professionals to think differently about their role within the larger care team and about the services the team provides. Next slide, please. We've made some advancements, but we have a long way to go. These are just some of the things we're grappling with. Like everyone, we have huge waiting lists for care and elective surgery, with people's health deteriorating while they wait. Within this challenge, there is an opportunity for us to stop providing low-value care services. Dental Health Services Victoria has already implemented clinician-led disinvestment in low-value care. We turned it off because of the pandemic. We're not turning it back on. We also need to look at introducing preventative interventions for those on wait lists, so they can be as healthy and fit for surgery as possible. And this is a way of bringing public health firmly into and integrating it into part of our healthcare system. Another interesting challenge is the perception of what value-based healthcare is, and both speakers have touched on this as well. Patient outcomes are not the same as patient satisfaction, and as Elizabeth Teisberg so eloquently puts it, patient outcomes ask, how are you, not how are we? If you'd asked an individual aged care resident what they wanted during the second wave, they would have probably wanted to stay in their home. But it's our job to look at the outcomes that matter to the residents, to the staff, and to the healthcare system as a whole, to lift our value-based healthcare models up to the population level interventions, to balance healing the person in front of us with healing the system. We have a lot of intelligence from our population interventions, and we need to use that to undertake segmentation of our community to ensure we can listen and communicate more effectively with them to both understand what is important for them and with respect to their health, and in turn grasp a better understanding about what providing value actually means. While we introduced COVID support grants that were not activity-based, those were only interim. Healthcare providers are still funded based on activity, and that's a major barrier in taking a preventative and value-based approach. We need to continue to work with the International Consortium for Health Outcome Measurement and the international value-based healthcare community and look at how we can integrate patient-reported outcome measures into state and national data sets and design our funding mechanisms around those. Next slide, please. In closing, here are some of the things we're looking at, and we would love to work with this amazing international community on deepening our wisdom and implementation. How do we leverage current reduced activity to stop providing low-value services? How do we seize the moment when traditional stakeholder boundaries are down so that we can collaborate, we can build that trust in this moment and learn from one another on a national and international scale? How do we embed preventative mechanisms for all people at all elements of the system, and particularly for those who are now on ever longer waiting lists for elective surgery? And how do we use the learnings over the pandemic to improve our management of other medical conditions? Next slide, please. So thank you. I look forward to working with you all to find new ways to deliver value to the community. Let's carve out that time on the balcony and harness the momentum of the last almost 2 years to create a more progressive, equitable health system, a system that realigns healthcare with its true purpose, to keep the community safe and well so that they can live abundant and meaningful lives. Thank you.
Diolch yn fawr. Thank you, Alice, Zoe and Joseph. 3 excellent presentations, and whilst in different systems, we have different system mechanics and challenges, I think there are a number of common themes and areas to explore across some or all of our presentations. If I offer some brief reflections on some of those themes, and then we'll turn to questions. So if delegates, please use the chat bar to pose your questions to the panel. I guess the first reflection is that clearly, as evidence from this session, there are a number of opportunities to collaborate and share practice on a shared ambition of really driving and implementing a value-based healthcare approach, and I think that's come across quite passionately from the panel this morning. I'm also struck by the impact and lessons from the COVID-19 pandemic and how that emphasises more than ever to me really how crucial a value-based healthcare approach is and how that has to be at the heart of recovery. And I think that's a common feature across all of our systems. I think it's also a clear focus for all of us that it has to be about outcomes that matter for everyone, individuals and their families. So there is a space for considering and recognising, I guess, a value approach at a population and condition level, but we also need to focus critically on each individual. And from that, good data and measurement is clearly vital. And I think each of the presentations have touched on the importance of that in different ways. And I guess finally, for me, from a personal perspective, I think I've just found from those sessions themselves, and being as insightful as they are, there are just obvious opportunities to pinch with pride fairly shamelessly and sort of share experiences across us as a system. So we've got around a quarter of an hour for questions. So I think the first area I think it's worth exploring is the pandemic and its impact in a value context. And the first question, which I'll direct at you, Alice, if that's okay. We've all advocated international collaboration. Do you think that COVID has helped or hindered with that over the last 18 months?
Thank you, Hywel. From my perspective, it has absolutely helped in a number of ways. We've all gotten used to having conversations on Zoom, picking up the phone. Zoe, Sally Lewis, and myself, we've said, okay, we have to pick up the phone and talk to each other when we're struggling. It's so easy when you're caught in the difficulties that this pandemic has caused to forget that there's a world out there of people that have struggled. and maybe going through the same things you are. So in that case, it's absolutely helped. What I will say is that I'm really looking forward to when we can all be in person again, because I think that you need those touch points, that face-to-face communication, at least every once in a while, to strengthen those relationships and build on things together.
Yeah, thanks, Alice. I agree. And a helpful plug to prompt Barcelona 2022 as a potential opportunity to do that. I guess another question for me that sort of falls out to that for you, Zoe, and I was struck in your presentation around this. I think obviously one of the consequences of the pandemic is longer waits for treatment and intervention. So how do you think a value approach can minimise the impact and potential harm for patients whilst they are waiting for that treatment or intervention going forward?
Look, thank you for the question. I think it's absolutely critical as we move forward. I think certainly identifying low value care on our waiting lists will be really critical, so that we can actually remove that low value care and allow those who need to access high value care to do so at a faster pace. I think the other elements, which I did also touch on in the presentation, is how do we have systems and processes integrated in our healthcare system so that we actually ensure people are as healthy as they can possibly be when they have surgery. We have a wonderful person from the UK, Professor Michael Roberts, who's come to join us at Safer Care Victoria, and he has really articulated very well, how do we actually identify with COVID messaging, if you stop smoking and you get COVID, you'll have a better outcome. But we also need this messaging to happen for all of our community more broadly, and particularly in a targeted way. I was really struck with one of the models of care that we implemented at Dental Health Services Victoria, was to take people off the wait list and bring them in for health promotion activities in a group. And that achieved multiple things that we didn't necessarily anticipate. One was patient activation. So we really saw people who were engaged with their care. We were also able to collect baseline outcomes so that we knew how those outcomes would change over time. We could triage in person, of course, as well. But really importantly, everybody went away with all the health promotion messaging and understanding of how to actually improve their own oral health. So by the time they got to the care, they actually were already in a much better position. And I think that's a really good model for us to learn from across healthcare more broadly.
Yeah, fantastic. Thank you, Zoe. I agree. Okay, question from Alan Wardour, and change direction slightly. Question for you, Joseph. So Alan recognises what you described, Joseph, around the failure colleagues sometimes have in understanding what value-based healthcare is, and Alan's reflection that we found similar challenges in Wales in other areas, including the term healthcare pathways, which is obviously a critical delivery mechanism for value, and that being open to similar misunderstandings. So I guess when you've encountered that issue, how have you addressed it, and any lessons you've got to share with us around that?
Yeah, thank you. So I agree with the reflections. One of the ways we've addressed it is exactly the same way that you addressed it at the beginning of this session. Every presentation we give, we share the definition of what we're talking about when we say value-based healthcare. And I think that matters. And the reason I think it matters is that definition, which was developed in 2019, critically includes the word equity. And some of what's missing in some of the US-focused models of value-based healthcare, Alice, this isn't a comment on your work, but on kind of the work originally developed at Harvard, is it's been very healthcare focused and not thought about that kind of broader health system, including health equity. And Michael Porter argues that value-based healthcare and population health have nothing to do with one another. I happen to disagree. And I think actually the structure set out in the question here is very helpful for us in thinking about the relationship between those different aspects of the systems. But let's be clear, from the patient perspective, that's not how a person experiences a system. A person just experiences all of that dysfunction between people, teams, organizations, systems. The role of the structure and the strategy is to give us that way of taking a complex, complicated world and trying to think, well, how can we together, working across all of those different boundaries, make progress so that it's easier, better experience of healthcare and improving health outcomes for everyone.
That's great. Thank you. Thanks, Joseph. If we explore that approach to population health and person-centered care a bit more fully. There's a question in the chat bar around how do we address some of the inequalities across the globe and take a collaborative approach. I'd probably broaden that a little bit to think how do we consider how we best implement an approach that best balances the needs of the population and the population health at scale, but also recognizing the needs of each individual person and some of the inequalities within that agenda. So if I can direct that question to you, Alice, but then the same question to you, Zoe.
Sure. In response to Joseph's comments, I completely agree with you. I think there absolutely is a relationship between value-based healthcare and population health. And we certainly suffer from misunderstandings, particularly most people think it's only about cost in our case. But in terms of equity, so if you were able to measure outcomes for every patient, you would uncover inequity just by that fact. Now, that doesn't mean that everything you do needs to happen at an individual level. You have to work at the population health level. But sometimes if you say, well, we really should focus only on the population level, that can hide those individual inequities. So it's a constant balance of individual and population. And yes, you'll have to make trade-offs at times, but being transparent about that and knowing what those trade-offs are rather than making assumptions about what they are is incredibly important.
Thanks, Alice. Zoe, same question.
Thank you for the question. I think I'm not sure I have a good answer for the inequities around the globe, but I would welcome any thoughts on that one. I'm certainly the lens that we're taking to how we're evolving population public health and value-based healthcare certainly in Victoria is if we get it right for the people who are struggling the most to access, for our Aboriginal and Torres Strait Islander people for whom there are inherent racism and barriers for access, for asylum seekers, for refugees, for people without homes. If we can get the system right for them, it will work for everybody else. So we take very front and centre a lens around Aboriginal health and how do we actually both learn and understand that Indigenous wisdom and bring that into our thinking around healthcare, because I think there is a much more holistic understanding of how individual health is deeply connected to the land and the earth, and we're seeing that play out more and more in climate. But also our system does not support their health and well-being. So how do we actually bring their lens, bring their voice genuinely to the fore in leadership, and something that we call self-determination. So it's actually about Indigenous people designing care that's right for them. And as a process, I think that's certainly a way to begin to address those inequities.
Yeah, fantastic. Thank you, Zoe. If I move us to the data space for a moment, I'm conscious of time. A question for you, Joseph, because the reference to AI, I think we've heard a lot across all of the sessions about data and its importance in the implementation of a value-based healthcare approach. What do you think the future holds for value-based healthcare from a data perspective, and how that will impact in your healthcare system?
Yeah, very good question. So first, a reflection. So I suppose ultimately value-based healthcare is a means, not an end. I think it provides us a framework for thinking about the role of data in supporting patients and professionals improving their health. I think why it's a helpful framework for us in making that progress is helping us think about who are the people that we need to bring together, the different experience and expertise across a kind of whole health pathways in order to make progress. So if I think about our example in London, we don't lack world-leading expertise or experience in terms of data capability, or indeed kind of diversity of population health data sets. What we have is a fragmented system, people operating in different silos and not being able to share that data in a way that supports and improves care, is embedded within those systems. And if I just pick one example, patient-reported outcome measures for hips and knee replacements was mandated in 2009, goes in, completed on paper, goes into a central registry, sits there, is incredibly hard to get out and actually use embedded within clinical care pathways. So I'm hopeful. I actually think we've got all of the different aspects in order to use data to improve health. But I think we continue to be immature actually in how we support and enable people to work together to use that data with their experience and expertise alongside and with patients.
Great, thanks, Joseph. I agree, and I think the reference to paper records brought a smile to everyone's face there. We've obviously all got some scars on that front. Question on spread and scale, and I guess I'll expand this to ask you to each answer two aspects to this. So the first is, what would you recommend we do to spread and scale value-based healthcare across our system? So if you could think of one pearl of wisdom around that. And my cheeky add-on would be, from the sessions you've heard this morning, what's piqued your interest in the spirit of collaboration as something that you'll take away to deploy within your system or explore that further? If I come to you first, Alice, and then Zoe, and then Joseph.
Thanks, Hywel. I feel like for spread and scale, I mean, we have to be able to put the patient's voice in front of people. So the more that we can do that, the better off we'll be. Those measures that get stored and nobody looks at, it's not compelling. So how do we make that compelling, and how do we bring those stories front? And actually, we found that this framework of capability, comfort, and calm has been helpful for that, for really helping clinical teams understand some of the challenges that they're facing. And then, I'm sorry, Howard, the second part of your question, can you repeat that?
Have you heard anything from your colleagues this morning and thought, I'd like to take that away and explore that further?
Yeah, and that's not cheeky. So many things, but Zoe raised the issue of how do we keep what's been helpful during this time and not go back to low value care. I think that's one of the critical questions as we move out of this pandemic for figuring out how to move this work forward. How do we prevent people from just going back to the status quo? And I don't have an answer, but that's something that I think we need to explore as a collaborative.
Thanks, Alice. Zoe?
I think in terms of scale and spread, you know, I'm a big believer in being opportunistic and always having the principles of value-based healthcare in the back of my mind and that framework. So the moment that I had an opportunity to work on the COVID positive pathways, I could see the integrated practice unit, and I thought this is such a window and such an opportunity for us to create an integrated healthcare system, particularly because the scale and risk of the pandemic means that those traditional boundaries and barriers that people keep, or their territorial guards, are dropped because the risk is so high. And now is the moment to seize it. Now is the burning platform that we have where people genuinely come together to collaborate because the outcome is so critical. And so, you know, we're actually now finding we are getting integration across those pathways. We're getting people really actively wanting to come and be a part of those pathways and integrated in that space. And I think that's a real opportunity for us, because we will pivot it to specialist clinics, we'll pivot it to other chronic diseases once we've got the mechanisms. And in fact, I'm keen to do that sooner rather than later, but perhaps we need to learn to walk before we run. Look, I really love all of what was in these presentations, and I learned a lot from all of it, but, you know, really always calm, comfort and capability just resonates so strongly with me. And how do we bring that thinking and those metrics and understanding into the patient consultation, because that's where it's actually really critical. Those outcomes and working with the clinician and the patient to understand where they are, where they want to go, and are they improving. So it's something that always resonates so strongly with me. Thank you.
Thanks, Zoe, and I'm conscious of time, but Joseph, any final reflections from you?
Yeah, I'll be very, very brief. So these conversations this week is what we need to keep doing to support scale and spread, not because Wales has all of the answers or any of us have all of the answers, but actually because we don't know the answers, and we need to keep sharing as we're making that progress that Zoe was talking about, and doing that rapidly. And in terms of that kind of cheeky question, the relationship between professionalism and purpose is something that I'm going to take out of this morning in terms of thinking about how we support, enable, because I think that's key to us making that progress and sharing something new next time we all come back together.
Fantastic, thanks Joseph. Okay, well, we've come to the end of the session. Can I just say thank you sincerely, Alice, Zoe and Joseph, for your time this morning and fantastic contributions. It's been wonderful hearing from you, and I'm sure you've given the delegates much to think about. So diolch yn fawr iawn, and I hope everyone enjoys the rest of the week. Thank you. Diolch.